Hello, everyone. Good evening. Welcome to yet another session of Journal Club. After so many interesting talks about the clinical part, about the infertility management from the clinical point of view, now we are moving on to the lab. I have the pleasure of inviting a very dear friend, a very eminent embryologist from Sir Gangaram Hospital, Dr. Gaurav Majumdar, as our expert. Rahul, can I have the CV of Dr. Dr. Gaurav, please? He's the lab director and chief embryologist at the Center of IVF and Human Reproduction at Gangaram Hospital. He has more than 20 years of working experience in ART. He holds a MCE degree from the National University of Singapore and a PhD in pre-implantation genetic screening for aneuploidy. In 2014, he successfully set up a PGS PGD program, which now successfully runs an in-house genetic testing facility using qPCR to screen embryos for aneuploidy. He is being awarded the Economic Times Fertility Award for Best Embryologist in the year 2019. He is Secretary Academy of Clinical Embryologists India and Chairman of Embryology Indian Fertility Society. Welcome, Dr. Gaurav. I have the pleasure of inviting another good friend of mine, Dr. Rajapriya. She is going to talk about the clinician point of view. Dr. Rajapriya is the Managing Director at Om Fertility Center, Srinivas Priya Hospital, Perambur. She is currently holding a managing.com member of Oxy, Foxy Sexology Committee member, executive member at ATNR and NRCOG, Secretary Indian Fertility Society Tamil Nadu chapter, Secretary Perambur IMA Women's Wing. She is a member of Foxy ICOG course coordinator also and Part 3 MRCOG examiner. Welcome, Dr. Rajapriya. Thank you for accepting this invitation. I would like to invite now Mr. Rahul Sen, who's going to be our presenter today. Rahul, I need Rahul's slide. Okay. He is MSc PhD and the Chief Consultant Embryologist at Neelkant IVF Center. Many positions to his, credit. He is nominated mentor of ASHRAE Mentorship Program, recipient of ISR Shining Star Award, recipient of IFS Achievers Award, past treasurer ISR, past executive member IFS Rajasthan chapter, scientific committee member at IHERA, and guest faculty for Rayat Bahar University Advanced Embryology Academy. So Rahul, stage is all yours. Please start. We want to know what happens when there is a total fertilization failure.
Is my slide visible? Hello. Yes.
Rahul, you need to
Slides are
stop
visible?
sharing, then Rahul Sen can start sharing. Yeah, we are seeing your screen. Can you move it?
Yeah. You can. Yes.
Yes.
Is it visible?
Yes, it is visible.
Okay. So thank you so much, Dr. Nisha, for this kind introduction and a very warm good evening to all. So as it is already known that we'll be discussing a lot about total fertilization failure after ICSI and what happens if there is an instance of fertilization failure, how it goes, how it happens, what pathophysiology situations happens during the fertilization failure, how we can diagnose it, and how we can further in future cycles we can manage it through artificial oocyte activation. This is all about we'll be discussing for next few minutes, and these are the objectives of the slide. The same we'll be discussing with the safety and safety concerns of artificial oocyte activation as a technique. So as we all know, fertilization is a series of dynamic and complex events which is triggered by sperm and oocyte interaction that leads to the formation of zygote. When we see there are these two pro-nuclear appearances on the day one of embryo growth, then we can assure that yes, there is the fertilization which has happened. And a normal fertilization is assessed by the two centrally positioned juxtaposed pronuclei, which are clearly visible here, and number specific nucleolar precursor bodies and well extruded two polar bodies. So if an embryo, if an embryo looks like something like this on day one, then we can assure that yes, there has fertilization which has been happened. And what we do in for the process of fertilization, we generally proceed with either with the conventional insemination, where COCs are exposed with sperms in the nearby, and then gametes are co-incubated together, and after a certain time, fertilization has been assessed. And in cases of ICSI, what we do is sperm is selected manually. It is immobilized and injected into the cytoplasm and cytoplasm of the oocyte, and then it is observed for fertilization assessment. So, what happens during the fertilization failure? We eventually end up in seeing no pronuclei, no extruded polar bodies, no pronuclear precursor bodies. So fertilization failures refers to there is no formation of pronucleus even after evaluating it at 18 hours of insemination. It eventually leads to a great financial and physical stress, not only to the patients, but also to us as an embryologist and to the clinicians also. Fertilization failure during ART is often unpredictable, and it remains an elusive task which needs more further clarification. And today we'll be discussing about this wonderful paper which was published in Human Reproduction Update, a recent published paper which was published in 2023 March, and the authors of this paper are Gerard Campos, a very dear friend Romaldo, and Sandro Esteves, hailing from Brazil. So we'll be demystifying this paper, how this total fertilization failure, even after ICSI, it happens, and how we can manage it in future cycles. So to introduce this paper basically had a background of evaluating fertilization failure only after ICSI. It has shown there is an emotional and financial burden to patients, and statistically, it has been confirmed that the fertilization failure is overall rated as 1 to 3% in the ICSI cycles, and it is actually a significant number, which is 1 to 3%, and it is again a significant challenge for all of us to rescue this FERT failure. And to this is all about to review this fertilization failure. And fertilization, as we have discussed, it involves a series of complex interactions. The process is basically initiated as intracellular calcium, which is being raised and oscillated in oocyte. And the key factors, the key gametes which involved are the sperm and the oocyte. The sperm, it may have a defective, or it may lack the ability to trigger oocyte activation. It can be a cause of fertilization failure. And oocyte factors, again, oocytes might have intrinsic defects which can lead to the failure of fertilization. And what happens in naturally nature, what it happens is, as soon as the sperm enters, or it reacts with zona pellucida of an oocyte, it basically triggers, and the pronucleus the pronucleus introduces an enzyme which is called as PLC zeta. This PLC zeta is basically injected into the oocyte, and this triggers a series of pathway, and which ultimately ends in oscillation of calcium ions and releasing of calcium into the perivitellin space. So sperm entry induces calcium oscillations in the oocyte cytoplasm, and it is critical for oocyte activation. and it is already evident in studies that oscillations are essential to resume meiosis and to resume the cell cycle. As we all know, the oocyte is basically arrested at at metaphase 2 stage. So the resumption of meiosis is basically required, and for the subsequent embryo development also. And these and there are the signaling pathways which PLC zeta initially triggers that eventually resumes the meiosis, and it is already evident that PLC zeta is basically an enzyme, and uh, it can be induced artificially to activate the oocyte and the embryo development. So there are the sperm related factors. Primary is the PLC zeta, and it is already evident. And another alternative proteins which are responsible are the POP protein, which is the post acrosomal domain binding protein. Another is citrate synthase, and another is c-kit tyrosine kinase. So these are the receptors which have been proposed that can be a cause of fertilization failure, which are related to sperm related factors. And these other alternative the chain of proteins basically are on the merge of ongoing research. Yet a more validation is to be done, whether they have any role in oocyte activation or not. But yes, PLC zeta is very much identified, very much evident, and it is one of the primary factor which is related to fertilization failure related to sperms. The factors which are related to oocytes are when it majorly it can be immaturity. We see mature oocytes as there is a extruded polar body, smooth cytoplasm. But even if there is an M2 oocyte, there can be immaturity in terms of cytoplasmic maturation. It can be immature in terms of nuclear maturation. So oocytes which are not fully matured, both cytoplasmically and nuclearly, so they can fail to activate properly. So there is a lot of evidence in the literature which propose that morphological and molecular studies, there are the higher chances of FERT failure in immature oocytes. There can be factors which are related to spindle abnormalities. The defects in meiotic spindle can also prevent proper oocyte activation. Even few genetic mutations which are related to WEE protein, patal protein, and tub protein, which are linked and related and properly documented, that have an active effect on the oocyte activation related to the fertilization failure. So genetic screening and functional assays revealing these mutations has the impact of oocyte activation. So what tests, what diagnostically we can actually see to eventually rule out the fertilization failure. It can be a chance, or it can be a situation to use the heterologous or homologous, like donor sperms or oocytes, to determine the source or the defect of fertilization failure, where the actually fertilization failure is happening, and in which of the gamete it is happening. It is already evident and documented in lot of studies. There is again an experimental study or experimental programming which has been done by a technique that called as particle image velocimetry. This technique basically assesses sperm movement, and this basically assesses the potential sperm movement and the fertilizing ability of sperm. And genetic screening, we are all aware of that genetic screening for known genetic mutations are associated with the oocyte activation failure. So what management it can be done? Conventionally, use of calcium ionophores, which are routinely available in market, and commercially it is easily, and it can be uh, uh, incorporated into routine ICSIs also, that the use of calcium ionophores and ionomycin to artificially induce calcium oscillations. It has been already evident in lot of studies that the use of ionophores, ionomycins has improved the fertilization. Not only it has improved the fertilization, but it has also improved the embryo developmental, the possibilities of good embryo development and good blastulation outcomes also. There are the alternative methods, there are the alternative chemicals which have been discovered, but yes, a lot of research and ongoing data is yet to optimize these methods. But yes, there are the mixed results. Not much evidence has been there. There are the alternative chemicals like cycloheximide, TPEN, roscovitin. So these are the chemicals which have the ability to induce oocyte activation. Other than calcium ionophores and ionomycin, the injection of recombinant TLC zeta RNA into the oocyte, it has again shown an promising marker to activate oocyte and to reduce the chances of fertilization failure. So we have already rescued, we have already checked diagnostically, we have evaluated, we have tried to manage the cycles. But what about the embryos which are formed after the strategies of fertilization failure? So, are these embryos safe to use? Are these embryos have the safety efficacy? There has been a lot of concern raised about epigenetic effects of these embryos which are produced via strategies of fertilization failure. And there has been a lot of research which has been done on mice models, that there are the factors like insulin growth factors which have been found as methylated, and it has been also seen that these the expression of insulin growth factors, they have been upregulated, and upregulated in the mice models. And it has been also seen recently in a recently published study that in neonates it has shown its effect as uh, lower birth in neonatal outcomes which are produced from the from the babies which are born by oocyte activations. So the recommendations are, it should be carefully counseled to the patients which are basically undergoing the oocyte activation. A proper patient selection should be there, and the use and the efficacy of artificial oocyte activation should be regulated, and it should be regulated and counseled in such a way that patients should know what are the ratios, what are the probabilities of using this technique and having these technique for their embryo production. So the future directions, further studies on long-term safety and efficacy of artificial oocyte activation is needed. There is again a small number of data which is there in the literature. The data number should be more, it is required more, and more studies are required to actually develop an efficacy, to actually develop the to actually standardize the process of oocyte activation. And yes, there are the ongoing research into gene therapy and novel oocyte activation techniques like modified ICSI can be used to reduce the chances of fertilization failure. So there are the more innovative strategies and treatments need to be evaluated, need to be analyzed, assessed, and to be used for the clinical purpose, so that we can end up in giving good results, not only good results in terms of embryo outcomes, but also in terms of pregnancy outcomes to the patient, and to have a good successful rates in in our routine IVF programs. So to conclude, key points from the review, it includes including the importance of understanding of both sperm and oocyte contribution, which can actually end up in total fertilization failure. It has the impact to emphasize the need of personalized treatment strategies and ongoing research and uh, 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 a proper evaluative strategies with the ongoing treatment modalities should be taken in concern while using oocyte activation for the total fertilization failure. Thank you. So I'll end up my presentation with a quote that the key to everything is patience. You can get the chicken by hatching the egg, but not by smashing it. Thank you.
Thank you, Dr. Rahul. It was very, very interesting and very detailed presentation, giving us a lot of insights. Now I would ask all my participants to post questions if you have any. Meanwhile, I'll start from the clinician point of view. Dr. Rajapriya, we know that it is a very challenging situation. We know that we all are scared of it. But as Rahul described in detail about what happens in the lab, how can we predict it in the lab? But is there any clinical parameter where you might be, have this thought in your mind that this patient might have a fertilization failure or might happen in such cases?
So generally, I think there are situations of unexplained infertility, right? Where everything looks good. They have regular cycles and the follicle tract shows follicles going on time, and then you think the male factor is good, the tubes are patent. I think that's when we look at micro events are going wrong. So at the micro events, one of the key things is I think whether the follicular genesis is giving rise to the good quality oocytes, and I think fur check, that's why it's such an important thing. No, we wait for the embryologist to always give a fur check report because we know, like, okay, step one, we at least got the embryos. And a lot of time, the M2 sites don't match with a good fertilization rate. But I think here the purview of discussion is strictly total fertilization failure. That means we have nothing to transfer. And that's such a difficult situation as a clinician for us because it's we who sit with the patients and talk to them about the whole scenario, right? So there are so many questions in their mind. Why did it happen? Will it happen again? So what do I do to be able to get a better outcome next time? And as we just heard Rahul say, and I don't think the oocyte activation happens in the very first time, right? It's some recommendation to be made for the next cycle they're going to attempt. So I guess we at least counsel the patient saying it's not unexplained anymore. This is probably the reason why the pregnancy did not happen until now.
Dr. Gaurav and Dr. Rajapriya, both of you, do you think that cases where we are expecting, say, suppose 14 follicles, or we are expecting 14 eggs, and we get less number of eggs, or can we start from there that there might be something wrong going on there, the FORT and FOI, will it help us or no?
I think Dr. Gaurav should say, no, when is
Yeah,
it they would decide that this
No,
person
no,
needs
we
activation?
we cannot
we
uh,
cannot.
we cannot predict because here we are talking of total fertilization failure, not poor fertilization or low
Yeah.
fertilization. We're talking of total fertilization failure, and especially in a patient with, see, the number of eggs is key here. When you're talking about a normal responder with a good number of follicles and with a good fort also, and we get a lot of eggs, then total fertilization failure post ICSI is very rare. It is most common when the number of eggs is very low. So seeing a total fertilization failure with one egg or two eggs or three eggs is very common.
Okay.
But seeing a total fertilization failure with 20 eggs, maybe you will see it only once in your life.
Yeah, and maybe that even is not correctable also. Even with oocyte activation also you will get a bad result.
No, probably no. You cannot assume that. But
Okay.
if you see a total fertilization failure, and if the cause of that fertilization failure is a deficiency in PLC zeta, say for
Mm-hmm.
example, if there's a deficiency in PLC zeta, and all other mechanisms of oocyte activation are working and they're in place, then replenishing those calcium with the help of calcium ionophore will work. And
Okay.
that's why in a lot of cases, calcium ionophore works beautifully. However, there are some cases where despite calcium ionophore, we see no effect.
So
Right,
Sandeep,
if I ask one question,
yes.
how would you assume whether the sperm has gone wrong or the egg has gone wrong? Is there a way of you to note it down?
It's very difficult.
Yeah.
Okay.
So there is in the literature they've described Mort's test, which is
Yeah,
a
more than.
mouse oocyte activation test, which can tell you about the ability the ability of a sperm to activate
Mhm.
a oocyte. And
Yeah.
ideally it should be done with the use of donor eggs.
Mhm.
However, then all ethical issues come in,
Mhm.
and donor eggs are very scarce.
Yeah.
Nowadays.
So they suggested that mouse eggs should be
Yeah.
used instead. And in that, they've given an index
Mm-hmm.
where they say that in case if the threshold of 20%, if less than 20% of sperm are able to activate mouse eggs, then definitely sperm is the culprit
Mm.
and is responsible for the total fertilization failure. However, if more than 80% activation is seen with
Mm.
mouse eggs, then it means
Yes,
that
yes.
then the deficiency is in the oocyte factors and the oocyte cytoplasm. And then doing a calcium ionophore is not going to help,
Right
right?
now, according to this new ART law, ethically is this allowed? I think using,
No, I
but
don't think so.
it is not allowed, right? This
No.
mode is not going to be
But I
allowed by
think with
Indian ART law.
mouse you can do.
No,
Dr.
but
Gaurav,
you
any
can.
insights on that? I don't think they commented on
No,
that.
it's not allowed. But just for the sake of your own means to
No,
for a
Your
mental
own
stability, yeah,
understanding.
yeah.
Your
what,
own
For own
understanding.
understanding, yes, that can
why are
then
you
it
saying
can be done.
why are you saying it's not allowed?
No, means it is mentioned in the law that one cannot use animal gametes or other than human gametes in the lab, and they cannot do any kind of experimentation.
No, this is a diagnostic test
I
which does
think
Yeah,
in
not
yeah,
have.
research
it's
setting it
No,
should
no.
be
yeah,
allowed.
it's for the understanding.
And you don't need to do this test in the IVF laboratory. Why will you bring in mouse eggs in the IVF lab? You will probably go to an animal lab
Yes,
and you can perform a diagnostic test with the help of yours, because this is a test concerning only the sperm. And those sperms have to be reacted against mouse eggs, and you have to see how many of those eggs got activated.
yes.
It's a
But
very
Guys,
simple
I
test.
have I
no, but
have a
yes,
lot of
again at
questions
the
here. I
no,
have a
but
lot of questions here, Rahul, in the chat box.
yes,
I would
again
like
at
to take them one by one.
just to clarify this again, animal labs who are actually working on mice eggs and everything, they also have been under the same circumstances that they also need all the permissions,
Permission.
clarifications, why they are doing this, for whom they are doing this. So again, it can be a, situation where one needs to check
This
on.
is so see, this is for academic purposes to
Yeah.
understand how you can understand the contribution of sperm. Nobody here has access to animal labs or will rush to an animal lab to perform this
It's a
diagnostic test.
hypothetical question.
Yes,
Yeah.
Okay, let's move on to the questions, guys. What all strategies do you use practically in these cases? Gaurav, I would love to hear from you.
we if it's a IVF total fertilization failure, then obviously you will then follow up with a total ICSI in the next cycle, and that should solve the problem in most cases. If it's a ICSI fertilization failure, if it's a complete fertilization failure post ICSI, then you will recommend using calcium ionophore in your next cycle.
Okay,
That's
so
all I can
without,
say.
there is nothing else we can do for those
No,
cases.
there is then the other option which can be perhaps thought of is, because still even when we are using calcium ionophore, we don't know where exactly the problem lies and
Yes.
whether calcium ionophore is going to help or not. So in that case, then theoretically, the only way you can figure out where the problem is by use of donor eggs, where you can take a few donor eggs, say you take 5 donor eggs, and you inject your sperm in the donor eggs. And if those eggs also fail to fertilize, whereas, the same, if in the same cohort of eggs, say if there are many more eggs and those eggs fertilize with some other sperm, but they fail to fertilize after injection with this, concerned sperm, then you are sure that the deficiency lies with the sperm. So in case in future you have to advise the patient or tell them that out of the egg and the sperm, which gamete is defective, you can at least say that.
But I clearly understand that this is very good way of, finding out. But I think with present law, this is
Yeah.
not allowed.
Very
With all the
difficult.
affidavits and permissions for one
Yeah, yeah.
particular couple.
Very
Yeah.
difficult.
Yeah.
Very difficult.
So is there any test or other features to predict total fertilization failure prior to the first one? Rahul and Gaurav, both of you can answer.
I wish we had.
Yes, I
So
do.
we don't. So
Only
we
only
don't.
thing, like I said, is that one can expect total fertilization failures in maybe very advanced stage patients with very poor ovarian reserves.
Yeah.
So it's very easy to land up with a total fertilization failure when we are dealing with only 1 or 2 or 3 eggs,
I
right?
think most of the questions are asking again and again same
Yeah.
thing. Is there any test to predict? So
And
how's your experience of using calcium ionophore? I think Gaurav detailedly explained that. We'll move on to the next one. Calcium ionophore or ionomycin to use during ICSI. That I think is right. Rahul has answered. Yukti is asking any mechanical methods for oocyte activation, sir.
No, it doesn't work.
That laser,
mm, no,
taking it, twitching
laser.
it with laser, it will help or no?
No, no.
No,
No.
laser won't work. There is a technique, once it was eventually uh, advised. It was basically coined by Dr. Thomas Abner. Basically, it is a modified ICSI technique. What they do is they just take a lot of while injecting the oocyte, they take a lot of ooplasm back in the injecting needle and then give it a circular motion and then release the sperm at the 9 o'clock position of the egg. So it is basically a typical technique, not much advocated. So this modified ICSI technique doesn't work in all situation, all scenarios of heart failure.
No, no, and modified ICSI is probably to improve your, outcomes in poor prognosis patients, but not for TFF.
Not for TFF. Yes.
See, you have to understand that where's the calcium going to come from?
Mm.
You need the calcium oscillations, which is missing during activation of oocyte. And if the PLC zeta is missing in the sperm, then no amount of mechanical,
Mm,
intervention is going to help.
yeah, it won't work here.
So you need the calcium. Either it has to come from inside, where the PLC zeta stimulates your release of calcium, or it has to come from outside.
Somebody's asking what's the treatment probability of using oocyte activation in those cases with very low fertilization rate? It's not fertilization failure, but the fertilization rate is very low. Is there any role of oocyte activation in that?
You could, it may be applied, but see, poor fertilization is more indicative of a oocyte defect, because definitely the oocytes which are getting fertilized, it means that there is no deficiency of PLC zeta.
Mm-hmm.
Okay, that molecule is being supplied to the egg by the sperm, but there is some deficiency in the oocyte which is rendering it incapable to fertilize. So you could try in consistent, poor fertilizations in case after case after case. People have tried calcium ionophore.
That's the only. And what are the potential risk and side effects associated with cytoplasmic aspiration during ICSI?
Well, cytoplasmic aspiration is a normal part of ICSI, where some amount of uplasm will go inside the injecting pipette, and that's how you know that the ulema has broken. And it has to be done within a limit,
Yeah.
so that only very little displacement occurs, so that you don't suck in the whole cytoplasm, because that's definitely going to cause mechanical damage to the cytoskeleton of the egg. So, but otherwise, sucking in the cytoplasm is normal.
Yeah, it's not a
And somebody's
significant.
asked, is calcium ionophore present in sperm tail also?
No,
No?
No, no.
no,
Okay.
no,
Okay,
absolutely no.
okay. So, Dr. Rajapriya, I would love to ask you, see, from the embryologist point of view, it is very easy to, I don't know, maybe it sounds easy. You come and inform the clinician that, okay, there is a total fertilization failure. Now, the patient is sitting in front of you. What would you do? How would you counsel? It's a tricky situation. And nowadays, all the more tricky.
Absolutely. So when it is coming, as you said already, if it is happening in a very poor reserve situation, already we are tuned the patient, right? You have very few follicles and you're going to have very few eggs. And this whole procedure is going to throw up surprises. Actually, the process of ICSI is an opportunity for them to create their embryos. So
Yes.
at every point, there is suspense. How the follicle is growing, how the oocyte is, how the fertilization is happening. My only discussion will be, I will be asking the embryologist, when do we announce? Do we announce it on day 1 or day 2? Sometimes they say delayed fertilization. And I
No.
guess what Dr. Gautam,
Yeah. Not on day one, ma'am.
yeah,
We must wait for at least one more
One more
day.
day.
Mm,
Okay.
I would consult with them and preferably have them sit along with me so that the patient has the comfort zone that genuinely this was an unforeseen thing and it has happened, and it is giving us an explanation that inherently, and research is showing more and more that some genetically things are going wrong where neither the embryologist nor the clinician has control. So what do
So
we
I
do
think
next?
pre IVF counseling is the most important part. And honestly, like you need to tell the patient that if everything had been right, you would not have needed to come here. The IVF process should be done to find out what is the problem, what is going wrong. People have this mindset that IVF kara liya, bacha ho jayega. It should be not done as a last resort. It should be done as a test to find out what is wrong where. So there
Potential,
is
yeah.
yeah, there is another question. Dr. Gaurav, do you predict a total fertilization failure with the asthenoteratous spermic sperm? Severe oats?
Uh, no, not really. Only in case there is severe teratozoospermia, or in cases of globozoospermia. There, having very poor fertilization or total fertilization failure, the likelihood is very high,
Is there a
especially in
difference?
globozoospermia.
Is there a difference in this, like from a tese sperm or a ejaculated sperm? Would there be a difference if it is more common in?
Yes. Yeah, I would say, see, world over, even in a lot of papers that have been published by Sandro Esteves, and all these guys who are, who've done a lot of research, testicular sperm, especially from non-obstructive azoospermia, it tends to perform, lower than normal ejaculated sperm. So whereas we see it's normal to have a fertilization rate of 75 to 80% with ejaculated sperm, for the same eggs, testicular sperm will have at least 10 to 15 percentage points lower
Okay.
fertilization.
Gaurav, I would
But it
just
is not linked to TFF.
Yeah.
It is not linked to TFF. Only severe, very severe teratozoospermia may be linked.
are there any tests to check for PLC zeta? Do we have anything? How, like for solely for the academic purposes?
In the commercial space, no.
Okay, but in the research labs, we do have.
Dr. Palermo mentioned that in New York, in their lab, they can test for PLC zeta.
Okay. It would be a genetic testing, I suppose.
Yes, yes.
Okay. Okay. So during counseling a POR patient, what rate of FERT failure do you think that you should tell them, percentage or something? I don't think that this should come as a first line counseling that FERT failure can happen. We can just simply tell them that okay, there is a possibility that fertilization failure may happen.
But
But
Dr.
any
Nisha,
percentage?
we give them the percentage as a routine post OCR, not initially, not in first line counseling, but once a patient undergoes oocyte pickup,
Retrieval.
oocyte retrieval, and then once they have finished their consultations with the clinicians, then in our center they have a embryology consultation with the clinical embryologist, where they are explained a lot of percentages of embryo conversion, of blastocyst formation, etc., 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 and where we also specify that we cannot guarantee fertilization because there is a 5%
Okay.
chance of total fertilization failure. It is a very small chance, but it is impossible for us to predict that who will have a total fertilization failure. It is just, and for IVF, we specify when we are doing IVF that there is a 5 to 6% chance. For ICSI, there is a 3 to 4% chance. So we always tell them.
Okay. Okay. So, like somebody wants to know about rescue ICSI. If there is a total fertilization failure in IVF, what would you do?
In IVF,
Yeah, in IVF.
okay,
In
because
the same cycle. Now
so
there is a fertilization failure.
rescue ICSI, yeah. So A, we cannot do a rescue ICSI after a total fertilization failure post ICSI. I hope that is clear,
Yeah.
right? We can
Yes.
only attempt a rescue ICSI if there's a IVF which was done.
Yes.
And that too, you have to keep two considerations in mind. That next day, when you see no pronuclei and no polar bodies and possibly no sperm binding to the zona also, those are the safest cases in which to do rescue ICSI, because there may be cases where you've actually missed the PN formation, or the PN have dissolved. So the timing, so, there's a asynchrony in the timing, and you've actually gone ahead and injected sperm where it was not required.
Oh,
So you have to make sure that there is no sperm binding, there are no PN, and there are no polar bodies. And then you will have to ask for fresh sperm. You cannot use the sperm from the previous day, which you may have, overnight it may be there. That sperm is not going to work.
a
So you
frozen sperm? Frozen sperm will work?
frozen,
Yeah.
frozen will work, but that 1 day old sperm will not work. So you'll have to call up the patient. You'll
Hmm.
have to explain to them that we suspect that there is zero fertilization. So we want you to come in and give a fresh sample. It's a very tricky situation to do rescue ICSI. Most people will do rescue ICSI with the previous day's sperm, thinking that they've done their job, but that will never work. So you call the patient, you ask them to come again. So you have to do a lot of explaining also, that why suddenly on day one you want another semen sample. And then you will prepare that sample, and then you will perform rescue ICSI. And in case, and most of the time rescue ICSI will lead to fertilization. And when you make embryos, you again have to keep this in mind that you cannot do a fresh transfer. You have to now freeze the embryos, because there is a asynchrony of 1 day between the
Yes.
endometrium and the embryo.
Yes.
So
Yes.
these are the things that you have to keep in mind.
And
So
what
I
if it
think, yeah, please
total
go ahead.
failure recurring again? What is the percentage?
Ma'am, we've had I can I can count 3 such instances where despite using calcium ionophore with a good number of eggs, uh, the eggs did not fertilize.
And what did you do in that case? You went for donor semen or egg?
No, then we use donor eggs to
Okay.
find out whether the defect lied in this, because blindly
You can.
advising donor sperm would be wrong.
Hmm.
So
And
then
what was
we
the
had,
outcome of donor egg?
yes, they fertilize with donor eggs, with donor sperm. When we use donor sperm, when we use donor eggs with the husband's sperm,
They fertilized.
They fertilized and they made blastocysts.
Hmm. Hmm. Okay. So, but now I think I'll have to take the questions fast. If severe odds, should we counsel them for donor sperm or still do the ICSI? I think we should do ICSI once, Dr. Gaurav.
Yeah. If there are
Definitely.
sperms, then we never advise donor sperm.
Okay. What type of head defects have the worst prognosis or higher chances of TFF?
I told you,
So,
globozoospermia,
Globus.
round sperm with no acrosome.
Okay. Srishti wants to know what is the scenario in ICSI with globus. They already discussed about that. Okay. Okay. Anything else? Dr. Rajapriya, any words of wisdom from you for counseling the patient for the next cycle?
Yeah, all the best that you don't have total fertilization failure. And
Okay.
yes.
Anything
do
you would suggest, Rahul and Gaurav?
Yeah. My suggestion will be better to uh, have a good evaluation check on gametes. Means sperm should be evaluated properly. Even eggs, oocytes, or even if IVF is being done, COCs should be properly evaluated and checked and later used for the procedures, because many things are hidden there in the gamete itself, so it can be later cross checked if there is any instances of FERT failure seen, so that we can rescue the next cycle.
Gaurav, have you seen any case where you had a FERT failure, total fertilization failure, in the next cycle without doing anything, the result was good?
Yes,
Has it
many
ever
times.
happened?
Many times.
Many times. So
Yeah.
that means that it's not like maybe this cycle something has happened.
Yeah.
So so this means that we with one cycle we cannot tell the patient
Yes.
nothing can be done.
My
We need.
message here is that most of the fertilization failures are on account of variation in oocyte quality, and hence, just by doing another cycle, a lot of corrections can happen.
Okay.
You know.
And any relationship with the kind of dose or medication? See, I am a minimal stimulation specialist, so I always come back to the dose of the medication. So do you feel that it has some relationship with the high dose or low dose or
It
something?
it may, but then we are talking of those centers, or maybe those cases where we've heard that very high doses of poor gonadotropins, which go into 600 IUs and 900 IUs. When that kind of dosage is being used, see, you will not see any adverse effect of a good gonadotropin being given in a dose of 150 IU or 225 IU. When we're talking about poor stimulation, we are talking about those kind of scenarios where maybe very poor quality drugs are being given in extremely high doses. So there definitely you will see adverse effects of that on oocyte quality, and then what follows is failure of activation and poor eggs and poor embryos and so on and so forth.
Dr. Rajapriya, would you change the stimulation protocol if you have seen a fertilization failure or something once?
I wouldn't, because I look out for the embryologist saying whether they were happy with the way the oocytes were. Supposing there are dark granular cytoplasm, if they're saying the oocyte morphology was not good, I might consider going into recombinant and things like that. If they said the oocytes were looking upfront good quality, I wouldn't mess with it, because they are at, if it is believed at the calcium ionophore and oscillation level, I don't think changing stimulation is going to be better. As Dr. Gaurav said, probably a better cohort of follicles after a gap.
Any difference, like instead of antag, you would go for agonist protocol or something? You already answered that. Okay, fine.
I
So
wouldn't.
there is one more question. Can any lab conditions cause TFF? Both my embryologists.
If it's the lab conditions, then it
Effect
will
all.
have an effect across the board on all patients,
On all patients.
not on one patient.
So maybe if you are having fertilization failure in all patients, then you go and check your lab.
Then 100%. Then that's like a
Okay.
very, very bad scenario.
So I would like a last message from all my experts, please. take-home messages for all the young upcoming clinicians and embryologists, what would you say? Dr. Rajapriya, will start with you.
Okay. See, I think as the other embryologist said, it's going to be one in a lifetime experience. It's not a scenario we look forward to often. It's a lot of pre-programming that ICSI is a procedure which gives them the best chance to form their embryos, and such an event should be foreseen in very low reserve patients. And we have to be sensitive as to what options we are giving. We can either blame the egg or the sperm, and very clearly say, even if we are using this artificial oocyte activation, it is again a research setting procedure. It's not an authentic approved procedure. And the patient, I'm sure, will understand if we are being very transparent and realistic in our counseling. So I think be truthful and be realistic in your counseling. That should be fine.
Dr. Gaurav?
Yeah, I completely agree that one has to be very transparent because it's a event which occurs very rarely. So there is nothing to hide. There is nothing to be, anxious about. If it happens, then rather it's your duty to tell the patient that there's, something inherently wrong with the gametes, and just go in a stepwise fashion to see if you can find out where exactly the deficiency is and then advise accordingly.
Yeah, otherwise they keep moving from one sector to another,
Yeah,
again doing the same thing again and again.
yeah.
And I would suggest that maybe clinician and embryologist should together sit and talk to the patient. That would
100%.
help in, yeah.
That is the most important thing that Madam mentioned, that all cases of fertilization failure have to be addressed by both clinician and embryologist.
Dr. Rahul, your message, please.
Yeah. Final, at the end, I would like to comment better have a good evaluation, document what you evaluate, and record each and everything so that these recordings or documentation can help you in later aspects. If there is any like FERT failure today, it can help you in next future cycles. So better to evaluate and document everything, each and everything what you see in the lab.
So capturing those images, you can compare what
Yeah.
happened in the cycle and this cycle. So storage of data.
Yes.
Thank you, my experts, and thank you, Dr. Rahul, for giving us this informative and wonderful talk. I want to extend my gratitude and thanks to IFS for giving us this excellent platform for discussing such things. Thanks to Dr. Pankaj Talwar and our secretary, Dr. Shweta Mittal. I would again suggest all of you to join IFS, which is like, a very academically oriented platform for solving all our problems. Young Turks, please go ahead and join. So, till the next time, thank you so much. And with
Thank
Thank
you,
you
Thank
so
Dr.
warm
much.
regards,
Nisha.
Thank you so
thanks
much,
all.
Thank you,
Dr.
Thank
Dr.
you.
Nisha
Nisha,
and
for a wonderful session and great moderation by you.
Thank you,
thank
Dr. Gaurav, for agreeing to be part of it. Thank you, Dr. Rajapriya.
It was my pleasure.
Thank you.
thank you. Thank you, Dr. Nisha, and thank you, IFS.
Bye. Bye. Take care. Bye.
Bye-bye.